if you understand pain, you're going to be able to understand how you can change it.
All right, good morning, everyone. We're in for a special treat. We have Dr. Nuñez, who's a doctor of physical therapy and has a background in pain science. And I know you guys want to know what that is, so we're just going to hop right into it. So first, again, thank you, Dr. Nuñez, for being on here. And thank you for all the knowledge you're about to just give us so that we can live more healthier and better lives.
Absolutely. Great to be here. And as I was saying earlier, I think it's just any opportunity to geek out and talk about pain neuroscience education. I think I will take it. So thank you for inviting me to be here.
Awesome. So you're playing both sides. So like you have a background, you're on the education side because I know you work at Emory, and then you're also a clinician. Like, so you're in the field too. Like, how do you balance both of those?
So right now I'm a full-time assistant professor and director of clinical education at Emory University and in the physical therapy program. I do that full time. So any clinical work I do on the side, working mostly with patients that I've worked with in the past and want to continue working with me. So my clinical aspect is outside of what I do. It's integrated, but it's not a part of my role at Emory.
Oh, I understand. So we're going to start with the big question. What is pain science?
What is pain science? So, I'm going to laugh and you're going to laugh at my answer to this, and I will answer this, I promise. But I want to, and this is the teacher in me, right? I want to throw back the question, what is your understanding of pain?
Oh, wow. That's a good question. So pain is anything that hurts that I want to stop.
Yes.
Yeah, that's pain to me.
Absolutely. So you hit it on the nail, right? In terms of it's unpleasant, right? So
right.
If you look at the standard definition that we use in the PT world and pain neuroscience world, we use the International Association, the IASP definition is International Association for the Study of Pain. And you mentioned it, right? You want it to stop, right? So it's definitely unpleasant. Right. They define an actually new definition out as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Wow. So that means that, and ultimately pain, absolutely, we want it to stop, right? But what we know about pain is that it is basically a danger signal, right? And it could be in association with actual or potential tissue damage, right? And so what we know about chronic pain and things like phantom limb pain, right? You don't have to have an actual tissue damage associated with something in order to have the experience of pain.
Right.
So that's kind of important to know, right? Because in order to answer what pain neuroscience education is, it's basically a framework of how we understand pain and what we use as clinicians to be able to educate our patients or the people that we're working with who are experiencing pain, and also help them to provide or help us to provide the best treatments to choose from along their pain experience journey.
Gotcha. So I want to ask you a question because what I didn't mention in the beginning was you have an extensive background in the diversity and inclusion in terms of how you approach things. As a doctor of physical therapy that focuses on pain science, are there disparities from your perspective in the implementation of pain relief as it relates to like different ethnicities, different cultural groups? Have you seen that? And so can you talk a little bit about that?
That's a really great question. So my experience with DEI work and social justice and advocacy, first of all, I think, and Dr. Sylvester will also attest to this, my passions lie in so many different things in terms of neuroscience and physical therapy and psychology and social justice and advocacy, right? So that's where the DEI lens comes in. And at the intersection of all of those things is pain, right? Or the study of pain. You can take a little bit of out of everything that I just mentioned, and at the intersection of that would be pain, right? So everybody experiences pain differently. It's subjective. My pain is going to be different from your pain, right? But pain is biopsychosocial, right? So you don't not only have the biological factors of pain, but you have the psychological, those emotions and thoughts around pain, and the social aspects, and social, like, think about the pain of exclusion. Think about the pain of society and racism, and things that can actually amplify an individual's pain experience. So it's social, it's individual, but all of it comes in together to play into somebody's pain experience.
Gotcha. So let me ask you a different question. So I have a personal feeling towards like opioids, and opioids being used solely for pain relief. And for mine, it comes from a personal experience because I have family members that they were placed on it and then they became addicted to it and then they could not get off. I've been told that, the medical community has they have a way of getting people on opioids, but there isn't really a formalized way of getting people off of it. In your opinion, is that like something that's, and I want this to serve as an indictment on the medical community. It's just, have you seen, or is there like a formal way of getting people off opioids, or is there actively things happening to help people get off of opioids to kind of prevent the opioid addiction? And I'm only asking because I've just seen it one too many times, even up to recently. But as a layperson, all I see is the after effects. So I'm just wondering, from your perspective as the practitioner, what is your experience with it and what are your thoughts on it?
Yeah, so that's a really good question. So, just to kind of backtrack and talk a little bit about opioids, and opioids do serve their purpose, right? And they basically work on our own individual endogenous system, right? To basically imitate endorphins, which are our body's way of actually, combating pain, right? And so actually opioids actually bind to receptors like chemicals in your brain. And they bind to receptors that our brain actually makes, like those endorphins, right? So they have their own purpose. The problem is with these opioids, right? They're given to patients and people in pain as the only as the only solution, right? And not given enough education about them, right? Because they can work in the short term, right? But they're not the end all be all, right? So if you're given these opioids, they can help in the short term, but if you're also just still fearful of pain, of movement with pain, right? You're not going to get back to doing what you need to do, right? And this is where the biopsychosocial and the pain neuroscience education comes in, to be able to educate patients about, yes, there are things that you can do in the short term, including opioids, including some medications, but ultimately it's going to take an integrated approach to be able to get the confidence to be able to move better and get you back to where you want to be. So those opioids, again, they're highly addictive, and the problem with opioids used in the long term, just like anything else in our body, right, in our brain, our brain and our nervous system gets used to doing what it always does, right? If you're doing something on repetition, if you're learning a language, right, and you learn it better if you repeat it, right? So anything done in repetition, our nervous system works. Our nervous system works to actually create those bonds stronger, right? They make those bonds stronger. And so, those opioids, if you're taking them for a long term, what our brain and our nervous system does is actually kind of decreases the actual our own ability to make those endorphins again.
Oh,
right.
Okay.
Aside from that, our body and our nervous system is always looking to see, we're always looking for input on our environment, right? And so if you have if you're on opioids for the long term, there is something called what is it called? Um, Opioid-induced hypoalgesia, in which case, you basically you're very sensitive. You're very sensitive to things that are not necessarily dangerous, because you're basically your nervous system is amplifying that volume up to get more information about your surroundings, right? And so things that are not normally dangerous could be interpreted as dangerous.
Can you give an example?
Same.
Can you give an example?
Yeah. So movement, right? If you're, basically sitting at dinner with a friend for 2 hours, right? That's not normally dangerous, right? But somebody with long-term pain could that nervous system, which is hypersensitive, could interpret that as dangerous, right? And so you experience increased pain.
Is this different from? Does this happen with people who take like over-the-counter or topical pain relief, or is that this thing is exclusive to opioids?
It's exclusive to opioids, right? In terms of that hypoalgesia, the opioid-induced hypoalgesia, your brain and your nervous system stops or decreases its ability to actually create those endogenous endorphins.
Got it.
Right. With the topical and over the counter, again, they work on different receptors. Mm-hmm. And so it's a different type of pain relief that you experience from the topical.
Got it.
So I have a couple of questions, because I want you to kind of backtrack, Dr. Nuñez. And can you explain, so if I were to step on a tack, because you talked about real pain or tissue related pain versus pain that there doesn't even have to be tissue damage for it to happen. So can you explain how those are, what happens if I step on a tack?
Yeah.
And in the brain, and what responses and everything, so people kind of understand that, so that they can understand, well, then where does the pain that has no input, no painful stimulus come from?
Right. So really great question, right? So if you think about all of our nerve endings, our body has amazingly 45 miles of nerves in our brain, our nervous system, and our nerves within our periphery, in our limbs and whatnot. So 45 miles of nerves, and they're always looking to keep us safe, right? We actually don't have any pain nerves, right? We don't have pain nerves anywhere in our body. What we do have are things called nociceptors, right? These are nerves that actually sense things like chemical changes, or pressure changes, or temperature changes, right? So if you step on a tack, for instance, right, those nociceptors will send signals or danger signals to our spinal cord really quickly. Our spinal cord will then send it to our brain really quickly, right? And our brain actually says, hey, this actually might be dangerous. You might want to move your foot away from that tack, right? So it's pretty quick. The way our nervous system works is actually pretty cool to keep us from, right, keeping us from stepping on that tack, right? And that happens in the immediate term. That's more kind of like an acute pain response that you would think about. What happens with chronic pain, though, right? We actually so think back at that biopsychosocial factors of pain, right? You have the biological processes, some of which I just expressed with the nervous system, right? Mm-hmm. And then you have psychological, which includes some thoughts and some memories, right? And so our brain actually learns based off of past experiences and beliefs that we're taught. Right. So if one day if you're walking again barefoot somewhere and you feel like something you stepped on is a tack, right? Your body might respond the same way, because your nervous system says, hey, we know what this is. Mm-hmm. Right? We're going to want to move our foot away, even though you're maybe stepping on, a sharp piece of paper or something like that. Right. So in that case, it's not necessarily tissue damage like the tack would be, right? But ultimately our body is working to our body and brain are working together to keep us safe.
May I ask a quick question there? Because again, I'm not a doctor or a physical therapist at all, but based on that, is it possible then that I could step on a rock, but the message, because of history or my past experience, my brain interprets that as the attack, and then I thereby feel pain, or what I interpret as pain?
Yeah, absolutely. That definitely can happen, right? But what we've also evolved, thankfully, as humans, to have our prefrontal cortex. We have the ability to actually help ourselves to discern the difference between a rock and attack, right? And in the moment, though, we may experience some pain, right? Ultimately, hopefully, when we do realize it's a rock, things will calm down.
Got it.
It works kind of like an alarm system. That's how pain works, right? It kind of looks to see if things are dangerous, and then if things like you step on a rock, that alarm system will go off, right? You realize it's a rock, and ultimately it will calm back down, right? Well, what happens with people who experience pain on a daily basis or have chronic pain, right? Remember, our nervous system works on repetition, and it gets better at the things that we repeat, right? And so what happens with people who have chronic pain, their alarm system goes off, right? But it doesn't quite all the way go back all the way down. In other words, it stays heightened, right? So it takes less for that alarm system to go off.
Got it. So I think right now I'm still blown by the fact that we don't have any pain nerves.
Yeah.
I didn't know that. I just assumed
we
that
don't have pain nerves. So pain is an actual output of the brain. It's an interpretation of what's going on from our environment.
So then two people can have the same thing, but experience different levels of pain based on what how their brain interprets it.
Absolutely, right? And that's why pain is so subjective, and we have those pain scales, right? And so somebody with a knee replacement on the same left knee, same age, same demographics, could have a 10 out of 10 pain after surgery, while somebody else could have a 1 out of 10 pain. So, and both pain experiences are real. You can't necessarily say that 10 out of 10 pain report is any less valid than the 1 out of 10 pain.
So it's the treatment that you do for the same thing, the knee replacement. One has a pain level of 1, one has a pain level of 10. How do you determine if it's the same surgery, same damage, but different feelings of pain? How do you do the the post-surgery treatment if the pain is different, but if the pain felt is different, but the actions are the same?
Right. So I think this is where Dr. Sylvester knows this. This is where physical therapists have an absolutely unique position, in that we can help to treat all of those factors that I talked about: the biological, psychological to some extent within our scope, and social factors. Right. So we thankfully have the opportunity to determine what in that person who's experiencing that 10 out of 10 pain, of the biological, psychological, and social factors, is helping to keep that person's alarm system heightened.
Right.
Right. The protocols for a knee replacement, actual exercise protocols and rehab can be standardized, right? They can go through the same things for rehab, for the biological processes, but we cannot ignore the psychological and social factors that come along with it. Right. So it's really up to the person who's working with that person, the 10 out of 10 pain, to help to decrease that sensitivity, right? So that they can attend to the protocols that are needed for the rehab.
Gotcha.
Right. So let's say that someone has associated movement with pain. So, but there's someone who has to move. So, and then let's say that this person also, the source of their pain maybe was traumatic. So I had a patient, and I'll just talk to you about it, and then maybe you can say, what would you do? What things might you consider when you're treating them, right? So he was at a peaceful rally about a year ago, and peaceful protest, excuse me. And when he left, he was shot in both of his legs. And as a result of that, he ended up being in a wheelchair. So went to get some help. And this organization said, we will give you all the help that you need, all the therapies that you need. And the one therapy that he went to physical therapy, and the clinic that he went to was an all-white clinic. And the person who shot him was white and he was Black, but he also went to a psychologist. So those are the two therapies that he opted to use his money for. So you, as the physical therapist, what are some things that you would consider about this person, I guess, as it relates to their pain? So whether it's, at this point, it was months later when I saw him. And so he was still in excruciating pain. And so what does that say to you? What things would you consider when you're treating him?
Absolutely. That is such a unique case. And I'm happy that you're able to share that, Dr. Sylvester. And also happy to hear that person was also getting help in the psychological realm, right?
Yes.
Counseling, right? Because if you think about it, right, again, I think PTs are in that very unique place to help within those three realms, but also within our scope, right? So to answer that question, I'm going to think about those three. There are a few things actually that help to help somebody's alarm system stay heightened, right, within the biological and psychological and social realms. Stress and anxiety, right? Mood and emotions. That's the second one. And then attention or focus.
Yeah.
Right? So all of those three things we really need to be able to address. I'm sure you did with your particular patient, but we need to be able to do that in an integrated way. And my first suggestion would be to help this patient to the max is to be able to coordinate care with the person who is seeking counseling with.
Yeah.
To help to be able to decrease the stress, right? Improve mood and emotions, and then also help him to focus more on not necessarily the fear around movement, but more of the confidence around movement, right? So if, again, what we're trying to do is kind of work with that person's nervous system to kind of geek out again with the pain neuroscience, to help that person's nervous system go from a very heightened, overprotective, sensitive system down, right? To kind of decrease that. But the psychological, the social aspects of that too, right? And that's where I think the realm of psychology would really help with, in terms of, the racial injustice and fears around, because it is a power dynamic of people who are around him, right? To be able to address that and acknowledge it and name it, in order to be able to move forward.
This is interesting. Is there a formal relationship between psychologists and physical therapy? Because it sounds like, from your perspective, like those two should always go together in order to provide the optimal experience or pain relief for patients. But I've never heard it stated before. But now that you state it, just makes total sense.
Absolutely. So there are a lot of different integrated facilities right now. Little big shout out to the Pond Center, the Grady Pond Center, who they are forerunners in treatment of persons with HIV here in Atlanta, Georgia. Right, they definitely have an integrated care team of psychologists, medical providers, one physical therapist right now, but definitely integrated. There are other facilities. Mercy Care would be another one, although they don't necessarily have physical therapy there. They have psychology and women's health. So again, there are different examples of integrated care. I think that it definitely should be. We should see more of these facilities, right? Kind of where persons who are experiencing pain especially with trauma, especially with, aspects of social justice that need to be addressed, should be able to get their care within under one roof, right? Where all of the providers are speaking the same language and understanding this patient, this person, and their experiences.
I think this is so important because I know that with Arthur, a lot of the people that benefit from what he does, they have arthritis. Mm-hmm. And so they are, a lot of the times they're in pain. They've been in pain for a very long time. Yeah. And there is people are not addressing the mental aspect of that pain, the reason that they're not moving. So then after they have the surgery, they're still not moving. They're in pain and they're still not moving. And a part of the issue is that you can, tell them you should move, tell them you should do these exercises. And because nobody is addressing that psychological aspect, they end up worse off after the surgery than they were beforehand. And we see that all the time.
Exactly.
And then like you said, if you live in that heightened state of pain, then you may end up having a procedure sooner than you needed it anyway, because you could have gone a longer period of time having withstood that pain or even addressing the actual causes of the pain, right, if someone addressed that mental aspect.
Exactly. And that's why I think pain neuroscience education is so important, because it works within that umbrella of biopsychosocial factors, right? You can fix a bulging disc, quote unquote. Mm-hmm. You can fix surgically replace a knee, replace a hip, right? But there are the other two factors of pain that absolutely need to be addressed. And here's the thing. So I kind of bringing in a little bit more psychology in here, taking a page off of Stephen Porges in his polyvagal theory. So I kind of think about people's nervous system, and ourselves included, our clinicians, right? Mm-hmm. Do you think about where you are the most, feel the most safe, right? And most connected with people, right? That kind of opens you up to be able to learn and to be able to heal, right? Kind of think of that as the green zone, right? And our vagus, this is where the polyvagal comes in. The vagus nerve helps us to kind of regulate between, you understand what fight or flight is, right? Right. So when danger is present, our nervous system will kind of kick in to help us go into that fight or flight kind of yellow zone, is what I think about it. Right. And then they also explain something called the red zone or the freeze zone, and where our body will actually freeze, right, or kind of shut down. It's kind of that step from green, yellow, and red into that freeze zone, right? So I always want to look at the person in front of me, whether or not where they are on that spectrum. If they're in that yellow zone, right, I've got to be able to help them to get into that green zone first. That safety and that connection is where the healing and ultimately balance will occur for that person to be able to attend to their own recovery.
Right.
And it's easier said than done, but kind of looking at where they are in that, with arthritis, right? If they're fearful and they're always in that yellow zone, right, they're not going to be able to move unless they know it's safe to move. Mm-hmm. Right? So we have to help them to get into the green zone. Does that make sense?
Oh, it makes perfect sense.
Perfect sense.
How do you teach this to students? Because I guess I would imagine that you can instruct a physical therapy student, how to assess, how to provide treatment, but how do you prepare them to help with the psychological aspects that they may be confronted with when dealing with patients?
Yep. That's a really great question. I think it's the standard for pain neuroscience education in physical therapy right now is actually on the table, right? We're looking at standards right now to be able to implement this, because largely our curriculum, physical therapy, other health providers as well, the medical profession, our understanding of pain, or the way that we're taught about pain, is largely within just that biomechanical point of view.
Right.
Right? We don't necessarily understand or aren't taught how to integrate the psychological and social aspects. And so all of it is really is trying to embed this within the curriculum. And it doesn't just start with physiology. It doesn't just start with anatomy. It starts with being able to understand the person in front of you.
Yeah. It sounds like this isn't limited to just physical therapy. Like it goes occupational therapy, everything. So is there like a coordinated effort to bring pain science as you've explained it to us across the different types of medical care?
Yeah, absolutely. So I've completed a pain science fellowship through Evidence in Motion. And aside from thank shout out to Adrian Lowe and Jesse Podolic of the fellowship in pain science there. But I also have a certification in therapeutic pain specialty, which is open to different professions: occupational therapists, psychologists, medical doctors, nurses. And all of that is just kind of teaching, again, that kind of basis of how you understand pain. Mm-hmm. And then pain science education really is being able to provide the person in front of you who has the experience of pain with their own knowledge of pain. Right? So that ultimately, to answer your first question, that's what pain science is about, is to help pain science education is to ultimately help the person in front of you understand their own pain experience.
Mm. With that, Captain, do you have any questions? I have one question.
No, I'm so excited. Ask your one question.
So, if you were facing a potential client, I know you don't have, you're focusing more on what you're doing, but if a potential client came up to you and said, listen, I'm suffering from chronic pain, knee, elbow, wherever, what would be some of the things that you would share with them, or some of the things that you would want them to consider? I know you can't give specific medical advice without assessing them, but what are some things that you would want them to think about to help them with their chronic pain?
Yeah, I always start out with their understanding about what's going on with them. So I want to know whether or not they've been told they've had that bulging disc, or they shouldn't stand up too long, otherwise their back will blow out, that kind of thing. So I kind of want to assess to see what they understand about why they are hurting. Right. And through that, with pain science education, I don't necessarily want to give them all the information about it at one point, otherwise, they kind of have that, you could get that kind of glazed over look, right? But I want to understand what they know about pain first. I want to understand what it is that brought them to get help. Right. And I want to understand what it is about, what's important in their life. In other words, their values-based goals that I can help them to achieve. Right. Those are the big three that I want to look at at the very first meeting. From that, again, that biopsychosocial approach, the pain science education, where they are in terms of the polyvagal system, the green, yellow, and red, right? And that can change from minute to minute, sometimes, session to session as well. All of that to help them figure out which treatments and which protocols might help them the most. Physical therapy, as I said, has the ability to help with all those three, biopsychosocial. But then do we need to refer out to a nutritionist? Do we need to refer out to, psychologists to help them with some of the faulty behaviors and faulty beliefs, right? And also thinking about medications that they might be on, right? So it really does involve an integrated approach.
Mm-hmm. Gotcha. Awesome. Well, again, I'm not. Catherine, do you have anything?
No.
Okay. All right. I just want to make sure. But Dr. Nuñez, first, again, this has been amazing. Like I didn't understand just how deep the pain was and pain science was. I really was, okay, this hurt me, and so that's it. Let's go take some medication. But you've really opened my eyes to the fact that all the things that are included in it. And as you were talking, a lot of things made sense because I had surgery in the military, and some memories in the military will make me feel, or what I think is feel the pain in my wrist. And I just thought that was just a fluke, but there was actually a connection to that. So that gives me a starting point to explore it. And so now you don't necessarily need to give some medicine, but there's something else there. So I want to thank you personally for that.
Yeah.
With that, if there were other people, other doctors, other lay people that want to just follow up with you and ask you more questions about pain science, because they may be like me and never heard of this before, where can they contact you?
They can contact me at my email address, anjanettenunez@gmail.com. I'm not necessarily on any social media at this point, but I always refer back to things like polyvagal theory and pain neuroscience education. Adrienne Lowe has tons of different information out there, as well as Lorimer Mosley. Again, pain. If you understand pain, you're going to be able to understand how you can change it. So the more you know, the more power you're going to have to be able to change it. And you can get help, right? Your nervous system can change, right? You don't necessarily have to stay where you are. We can definitely help you.
Awesome. Can't get any better than that. So thank you again.
Yeah, thank you.
For joint relief, choose MegRelief.